All right. To create a PowerPoint slide deck like this is somehow refreshing and reflective for me. And I also learn very much from your questions. Toward that end, I've attempted to allow time for us to do so. So I have probably maybe 35 minutes worth of didactic, and we'll get to some questions. So indeed, I've framed this talk in a different way than you've probably regularly heard, and that is that it's been a nightmare, right? There are features about this that are greatly challenging to us. So in spite of the fact I've been a disease investigator, an outbreak investigator since 1998 now, I find that there are features of this that are really challenging. And indeed, one of the worst is that it's taken over our lives in so many different ways. So I do pause to note that many people have been personally impacted by this, professionally impacted, and certainly we all live with a new appreciation of how life can change on a dime in the era of emerging infectious diseases. So I'll review some features of the timeline that for me are appropriate to this topic. I'll give you a refresher on some epidemiologic features. I'll highlight unique challenges that we're facing in those trenches, and again, hope to find some time for your concerns and questions. Here's the pandemic timeline. It's really crazy that we have only heard about this in public health since about New Year's Eve in 1919. So the World Health Organization's country office in China was formally alerted that there was recognition of an outbreak of pulmonary disease that was not otherwise explained. The look back shows that it was circulating only probably for some weeks ahead of that report, and there are still mysteries surrounding that emergence. However, very shortly after the public announcement, there was a public posting of the genome or the genetic material of this pathogen, and it was a virus that no one had ever seen before. So this starts—
Dr. Talbot, your audio has quit.
How funny. Do you hear me now?
Yes, we can.
Okay, so sorry, I'm not sure where I got cut out, but it seems like the forces are converging against us here. I hope that you heard that we had kind of that oh no moment with regards to the fact that this is a virus that had never been seen before in humans. In response, there was a declaration for a quarantine to ensue in the area which was most impacted, of course, Wuhan City. And the announcement of that impending quarantine is credited or discredited with probably the first global dissemination of this, whereas before people had been individually deciding to leave. This was a mass exodus from the region as word got out that there was going to be such a quarantine. Not surprisingly then, given global mobility, the first case was identified in January 20th in the United States. And by a week later, we had some additionally bad news that the virus seemed to line up with an animal source. There were several lines of evidence for this, and I think that really this prompted the public health emergency of international concern. Let me talk about that for a moment. So these two features together do start to create that nightmare for us all. And that's because COVID-19 is recognized as zoonotic, right? This is always a bad feature for an emerging infectious disease. It means that humans have no immunity to it, and it may behave in ways that are not similar to the ways that human adapted viruses behave. So many of you have heard that the virus most closely lines up to a bat cold. So we've seen that before. That bat in the upper left corner is an incredibly common bat that seems to be routinely infected with this coronavirus with some differences. And it looks as though, although the story is not fully told, that the pangolin's cold virus resorted in such a way that there was a mechanism provided to that bat cold virus that allowed it to jump species. So from bat to pangolin, and then the pangolin's cold virus resorted to the bat virus, allowing it to infect humans. So the virus was recovered in highest density in the area of the market that this disease was first associated with, in the area where wild animals were alive or dead and sold in great numbers. So just in principle, to provide us lessons from other zoonotic emerging infectious diseases, I want to say first that most emerging infectious diseases are zoonotic. We often think of the rat as a classic reservoir for diseases that affect humans, but in general, more than 60% of known human pathogens are zoonotic, that is, have their normal life cycle in animals, but almost 3/4 of emerging new pathogens are zoonotic. Most originate not in domestic animals, but in wildlife. And that rate of emergence is increasing. So it's not that we have greater media attention or better molecular methods for detection, but indeed the rate of emergence of zoonotic diseases in humans is increasing in our species. So I think you can think of any of your favorite diseases and think associated animals. So of course, as I said, rats are important in transmission of a lot of different, especially bacterial diseases. Black Death, Yersinia pestis is one. Even domestic animals get in the way of human health, and here this picture is meant to reflect variant influenza, where we see in even northern New England occasionally as a result of county fairs. There's avian influenza, which has as its normal host domestic fowl and wild fowl, and because of human proximity to such, especially in Asian culture, there can be a species jump. In the Middle East, there's a close relationship to camels, and this has been credited with the emergence of the closely related Middle East respiratory syndrome, or MERS-CoV. These two animals are implicated as reservoirs for SARS-CoV-1 back in 2003. This is a civet cat on the left and a raccoon dog on the right. There's also a pet peeve of mine, aptly named, because the exotic pet industry has resulted in people introducing diseases in places they've never been before for humans. So both of these animals are victims of exotic pet trade, and I wish people would be satisfied with cats, dogs, and goldfish myself. I think in general, I'd like to leave you with the thought that as a disease investigator, I'm very concerned about the human interface, especially with wildlife, and that has really borne out in spades for SARS-CoV-2. So back to our timeline, which now will put a perspective from the U.S. on. You know that as these things unfolded very rapidly in January, it culminated with a public health emergency declaration and then a presidential proclamation for restriction of human movement in a way that had not been seen in modern times. So the closure of the U.S. border to flights from China, for example, this was a very challenging circumstance for us in public health to find out about it on the news ourselves. By February 26th, we moved from a sporadic identification of human cases to recognition of sustained community transmission. And by March 2nd, we confirmed the first case in New Hampshire. March 13th, in response to additional cases, the New Hampshire declared a state of emergency closely following the U.S. declaration. So let me pause a moment and say this rapid global spread has been a nightmare. Of course, it's moved very quickly for several reasons. The mechanism of transmission of this virus is a worst case scenario because it's very easy for humans to transmit diseases through respiratory droplets. That's high 90% of what's driving this epidemic. Yes, fomites or objects that have been contaminated with human secretions may have a role, but it seems to be very small. The ease of importation of cases due to widespread global travel, of course, is the era we live in now. And then the fact, because this is zoonotic, that there's been population-level lack of immunity completely. This is a novel virus, and there is no herd immunity at all. And now we're going to move into some epidemiologic features that I know this audience is in lots of different levels. So I'll just give some basic concepts that I think will be immediately intuitive to you, even if you're not an epidemiologist or a scientist or clinician. Certainly, heavily scrutinized is the lack of early testing. So I'll talk about that in much more detail in a moment. But the epi features that I draw to your attention in aggregate here are the fact that this virus can transmit before somebody realizes that they're ill. So pre-symptomatic transmission is a terrible feature in an infectious disease. You remember during the 2013-14 West African Ebola epidemic, at least we had the tool in the toolbox that people were not contagious if they were asymptomatic. So that's a feature we like in efforts to control a disease. But in fact, it's worse than that because there can be asymptomatic transmission. That is, people who never develop symptoms can also transmit disease, probably less than those who are spewing, coughing, sneezing. But indeed, it does appear to happen. And then there's a phenomenon that we really hoped wasn't true, but in fact has borne out as an important way this virus gets a foothold in different geographies, and that is super spreader events. So this is the second feature of this virus that I want to highlight as really nightmarish. This is today's pandemic status. So this is a very nice resource. You know, huge kudos to Johns Hopkins University for keeping up this way that we all can take a look at a dashboard and understand the global picture. We are approaching 10 million global cases, which clearly is a massive underestimate of disease. 500,000 deaths have been recognized, but we believe also that that is an underestimate. And then a particular tragedy in my mind now is the movement of the epicenter to south of the equator. So the low and middle income resourced countries are now being so heavily impacted, such as Brazil and Mexico and others. The epi curve in the lower right of this dashboard setup is concerning to any disease investigator. We clearly do not have this pandemic under control. So let's come back to this testing issue. I know that you'll ask questions about that. We all have questions about that for sure. So I'll make a bold statement. This has been just a terrible place for us all. The lack of early and continued lack of accurate testing has been a great hindrance to our pandemic response. So let's review that there are really 4 ways to detect this virus in a person. First is to actually culture the virus. Let me just say out of the box, nobody's doing that. It's hard to do, and it's a bio risk. So that's not really an important place of diagnosing people. But rather, we've depended heavily on RNA detection, so detecting the genetic material of this virus through polymerase chain reaction, or PCR. And when people say testing, that's usually what they mean, but we're at a place where we probably need to move to become more intentional when we talk about testing. So PCR testing is testing the genetic material. We now have widespread availability of antibody testing. So this tests for a patient's remembering having seen this virus. So this is a body's response to having seen this exact virus. And then the 4th way is through testing for other bits and pieces of the virus besides RNA. So this refers to really the proteins, such as the nucleocapsid proteins shown in the diagram, and also those knobs and spikes that make up the crown of this coronavirus. So let me say a couple of things about these different approaches. Again, first, nobody's culturing, but that's the only way that we have to know that somebody is actually contagious to other people. That's an important feature as we try to control this virus. The detection of RNA, the PCR, may or may not indicate that somebody is infectious to others, because it looks like that RNA lingers in a person's nasopharynx and throat for a long time after, they are infectious. Antibody probably means they're not infectious anymore, but we don't know that for sure. So I'm going to talk about that in a minute. And then antigen, which is the newest kid on the block, also may or may not indicate that there's viable, infectious, contagious virus present. So let's go back, way back when the CDC first announced that they had developed and obtained approval for the use of the PCR test, which is still the one that's in most widespread use. So the RT-PCR, the reverse transcriptase PCR, was first FDA authorized on February 4th. It was sent out to partners such as those of us in public health on February 10th and then promptly recalled before it went into widespread use because one of the tubes, if you will, in this package were found to be contaminated. A lot of effort to clean that up, and by February 28th, the use was re-allowed, and by March 2nd, our own New Hampshire Public Health Laboratory had validated and begun use of this test kit. Now, of course, many commercial labs and academic labs as well offer this. Still, the U.S. lags dramatically behind other developed countries. When you consider our population-based use, we're way behind. So in spite of what you might hear from the White House and those promoting the access, I think many of us, I hope all of us know that that's actually not yet the case. I want to talk about challenges at every step of the pathway to get tested, not just having a kit in your hand. Patients have to seek care. So I've already said that patients can be asymptomatic or pre-symptomatic. Maybe symptoms are so mild they don't even bother going to a doctor. They don't want to go to healthcare when they're afraid of getting infected if they don't realize what they have is already COVID-19. The test has to be available. That's been a problem. Clinicians have to be willing to test. They have to be permitted to test by their facility. And facilities still, clinics still are resistant to test people who are asymptomatic. And then the sampling process, getting the specimen, has to be enabled. There has to be an equipment supply chain available for safe testing, such as personal protective equipment for the healthcare workers who are going to take that sample. There have to be the right kind of swabs to grab it. And then there has to be the right transport media for moving it to the lab. That is, we need the courier to get it there and then the lab to be able to work. All of this together in that previous bullet are that the turnaround time, that is from the time a patient feels sick and presents to care to the time that they get an answer, yep, you got COVID, it has to be short enough that we can make a difference. So again, I create these graphics to try to explain some of these features. If a person is infected by somebody, they've been sneezed on, they've been coughed on, they have their incubation period, and then they have a symptom onset. RNA testing, the PCR test, is positive likely a day or two before symptom onset, and then for a few days after. Now let's talk about antibody testing, which has a really different place in the timeline of a patient's illness. You've heard already me say that this is a diagnostic that reflects a body's memory of having received it, an immune reaction. And we don't know right now that that immune reaction is effective against future infection. We don't also know how long it will last. So tons of unknowns about the antibody test. And right now, it's hard for me to craft a slide that gives a pretty robust sense of utility. For example, it's made after you've had this infection, probably getting better or better already. It's not useful for diagnosing acute illness, to say that a different way. And therefore, the proposed uses might be just public health to understand how disease is spreading in a community, maybe to identify plasma donors whose antibodies can be helpful to somebody who's critically ill, and then to understand the role of this asymptomatic spread, which you're seeing studies of regularly. Again, that new kid on the block is antigen testing. So that's testing pieces of the virus that are not the whole virus or the RNA or the host response. This I've crafted intentionally as a smaller block and think that the window of opportunity for using antigen tests probably is after that of the RNA, probably synchronous with symptom onset, and then does not last very long. We don't know. But these antigen tests are intended for acute infection, and they are favorable for the fact that they're less costly to manufacture. They can be made fast in bulk. They provide clinicians near patient testing capacity. That is, you don't need to courier it anywhere. You can probably use it in your own office, very similar to the flu test or the rapid strep test that many of you are familiar with. And positive tests are highly accurate. If you get a positive test, that's great. However, negative test results are quite inaccurate at this stage. That is, you can't depend on a negative test to be actionable. It gives lots of false negatives, and therefore we're really very actively trying to imagine ways that we could use this test. Where do we position this among the diagnostic efforts? So number 4, in terms of what makes this a nightmare for all of us, but me as a disease investigator, is that it's got some awful epidemiologic characteristics. So first of all, as mentioned, asymptomatic, pre-symptomatic transmission make it very difficult to control. It's also got this high R0. So those of you who are an epidemiologist will immediately understand this just means that a single infectious person will infect 2 to 3 people on average. This disease has a very short incubation, so we have to act fast. And then what's particularly awful and maybe less well recognized by the general public is that it's got a shorter serial interval than most infectious diseases we usually deal with. That is, the time from one person recognizing that they're symptomatic to the next person they've transmitted to becoming symptomatic is actually shorter than the incubation period for patent symptoms. So this means that we've already lost the battle by the time we've identified the first patient. And then these super spreader events you have heard about in lay press. By the way, we're told in epidemiology school equivalent that you're not supposed to use the phrase super spreader because it sounds scary and it can be very stigmatizing to the person who's called a super spreader, but it is readily understood, so I choose it here. You've heard about these clusters on cruise ships or military ships, like think the Diamond Princess, what a terrible thing that has been. The nursing homes, meatpacking plants, ski resorts in Europe have had a terrible time. Churches, restaurants, hospitals, and prisons, where one person far exceeds the expected R0 of 2 to 3, and that is they infect dozens of people. So I could make a whole talk on all the interesting super spreader events, but like a single Zumba class in South Korea with the majority of the class infected, probably the heavy breathing and the circulation of that closed room in another ideal environment for this virus to spread. Nearly half of employees in one office building were infected by a single person who was symptomatic. And then there was a, I think, particularly tragic event in Washington State where one person in a choir at a church was symptomatic and attended 2.5 hours of choir practice in spite of that. And 53 of the 61 persons present became sick. 3 required hospitalization and 2 died. So this is a closer to home super spreader event. And then we have some recent large-scale studies where, for example, in Israel, they suggest that 80% of transmissions, 80% of cases probably link back to only 1 to 10% of the overall cases. So really there seems to be a differential, and the R0 as described 2 to 3 is probably just that. It's an average and there's a broad range. So I want to talk about the high clinical impact because clearly this is what makes this such a horror for us all. You know the symptoms, but I want to talk more about hospitalization and death and the recent, the better understanding of what's happening in disease. So first of all, many clinicians think about this disease in these 3 stages. First is early infection, where the virus is getting that foothold and dividing and starting to do some damage. Second is when that damage is occurring in the lungs. But the third stage, which I think is not broadly recognized, is when the virus might be completely gone, really. And the problem is there's a overabundant immune response, and there's damage done by one's own immune system. So, this is horrible, that we've been hijacked, essentially, toward a higher morbidity and mortality by this virus that somehow takes over our immune system response and creates damage as opposed to rescue. So in the early viral phase, the majority of people present. So this is 80% of the cases that we recognize are and will only stay in stage 1. Ultimately, about 15% go on to severe disease, which often requires hospitalization and support. 5% go on to critical disease, which requires intensive care unit support and usually ventilator support. I think talking points have been useful from the very beginning. It was super hard to hear the talk about this as just a flu, because from the very beginning, the earliest days, we recognized a consistent reporting that this was not just a flu. The case fatality rate in the global reporting arena has been about 1.4%. But it's all over the place. Where there was collapse of healthcare system in the Hubei province, that case fatality rate went all the way up to 18%. So how devastating is that? Italy experienced a very high case fatality rate as a considered jurisdiction. And in New Hampshire, we have been riding consistently at a 6% case fatality rate. I know that you follow the news and you see that, but just to pause a moment on that's very high. That is nowhere close to flu, and we do state, our talking points are that seasonal influenza has a 0.1% seasonal case fatality rate. And even that is credited with a tremendous impact in terms of the hospitalizations and death. For comparison also, the pandemic in 2009, referred to as H1N1 or swine flu, had a case fatality rate 4 times higher than seasonal influenza, but far below what's happening in COVID-19. The closely related SARS-CoV-1 and MERS-CoV have much higher case fatality rates, and that may be why they burned out fast and have gone away, but thank goodness we're not there. So this reflects digging down a little bit more into who's going to suffer that case fatality. So first of all, a consistent risk that's been identified is male sex, and that's shown here. Also having comorbidities. If you have no comorbidity, your risk for death is probably lower than even what's usually reported. If you have cardiovascular disease, it's 10 times higher. Diabetes attributes risk, chronic respiratory disease, hypertension, and cancer and other conditions that compromise immunity. So this is something that everyone needs to assess on their own with regards to positioning their risk factors. Another terrible emerging risk factor within the United States is obesity. So 40% of American adults younger than the age of 60 have a BMI of 30 or higher. Remember, normal is 18 to 25, 25 to 30 is overweight, and over 30 is obese. So we continue to see data such as that which has emerged from the NYU hospital for the Manhattan event, where BMI is associated with the risk for admission to the hospital and also to admission to critical care or ICU. So if your BMI is more than 30 to 35, it's twice that of those who have normal weight. And if it's greater than 35, it approaches up to 4 times what a normal weight person would experience in terms of a need to be supported in a critical care unit. This starts to have significant implications for younger Americans, although I think that in the beginning we recognized elderly were at highest risk for morbidity and mortality. The shift is slightly toward understanding that's because they have comorbidities. Those younger persons in our society who have comorbidities putting them at risk, no matter their age, are going to then be at high risk for admission, hospitalization, and ICU stays. That's shown in this graphic, which came out recently in the CDC's publication looking at the national experience, where in the second set of graphs, underlying conditions for those who wound up getting hospitalized, obesity was a really important thing for those who are in the age group of 18 to 49, shown as that gold bar in the second grouping. I think we need to come into closer focus that race and social factors are going to influence risk. So I know you're hearing a lot about that, and it does warrant saying Black Americans have a higher case fatality rate, even when you adjust for income, having health insurance, comorbidities, and other factors. But the real driver of disparities are the quality of healthcare, access to testing, with systemic inequalities likely factoring into the increased risk. There's a very recent study showing that racial and ethnic minorities, even not in the typically concerning age bracket, experienced a 5 to 9 time higher mortality risk than their counterparts who are non-Hispanic white. So this positions our current pandemic analogously to 1918 in terms of transmissibility and clinical severity. So this is why we've all been derailed from normal life as we look to the toolbox for what we can do to control it. So this has been, an immensely frustrating space. We don't have many tools in that toolbox to control this pandemic, but I want to talk to you for a few minutes about what we do know. This graphic shows that if you do nothing, if you just let it run its course, such as has been chosen in some Scandinavian jurisdiction, you might see a peak like the black line here, right? So don't see this as get it over with quick. It's only meant to show that this kind of peak in an epidemic curve will disable our healthcare system. So this is the disaster that we absolutely have to avoid, where people who need them can't find ventilators, where healthcare workers become ill because we run out of PPE, there's no one to take care of anyone, and hospitals turn people away. So there's every reason to avoid the black curve. And then this model shows, based on data of how different countries have responded to this epidemic, how they will influence that curve. So the green shows a big impact of just closing schools and universities. And of course, many places have taken that option. This orangish is putting public health on high drive by case isolation. How about adding quarantine of people who might be at risk of coming down with contagious disease, and then adding social distancing. So it looks like the greatest bang for the buck will be case isolation, that is, keeping people who are sick away from people who aren't, quarantining those who may come down with contagious disease, and making sure that everyone is social distancing at least 6 feet from one another. In New Hampshire, we have experienced something of a lull in our epidemiology, but I want to give you this snapshot. So we have had more than 5,600 PCR confirmed cases. We've also experienced consistently a 6% mortality associated with those cases. We have had a 10% hospitalization rate for all our identified confirmed cases, which is, high and challenging in the setting where I'm sitting now, for example, in the hospital. We have ramped up testing. We have more than 10% of our population now had access to polymerase chain reaction. Some people are seeking antibody testing, I think for curiosity's sake. When they were ill in the beginning of this and couldn't get tested, they want to know. And we are continuing to address the access to testing statewide. It's been a tremendous effort for us to do the monitoring and the case investigation of all of these cases and contacts to cases. And the map on the right shows you what I think you likely have been paying attention to, where the greatest risk is in the population density, but also in proximity to Boston and Massachusetts, where the epidemic has been stronger, harder, worse. Besides that static picture, I think you are all following as well the fact that not all states are doing as well as New Hampshire, although we in this graphic from Johns Hopkins University have come down as our partner states, Maine and Vermont as well. Some states shown in the more red colors are increasing their case counts. This is a very powerful graphic from CNN showing in this recent week that there are increases and not decreases in the majority of states, and therefore I think that we will have to pay continued attention to our not-so-sexy control efforts. and yet balance that with the very clear mandate we have to reopen America. So I know this is a highly contentious issue where there needs to be a balance between reducing disease, but also addressing the terrible economic impact that these closures have created for our society. The Reopen America plan put forward by the White House is described in 3 phases to incrementally relax social distancing measures. And there's lots of guidance on how to move from one phase to another, including those features shown. There is also a mandate in parallel to create a capacity to treat all patients, make sure that you have appropriate bed space, ventilators, healthcare workers, et cetera. There needs to be a robust PCR testing program, and it's listed especially as for healthcare workers. And there has to be also an emerging antibody testing program in order to move through these phases. I'd spend more time talking about it, but to me it feels as though we've not followed gating criteria nationally, and there's been a very inexplicable acceleration of the opening that disregards some of those epidemiologic signals that we're seeing. Just last week, we had Executive Order 52 in New Hampshire in response to our favorable epidemiology. And this states that people who are older than 65 and those with underlying health conditions are still advised to stay at home. Leave only for essential needs, wear a face covering, monitor for illness, and everyone else who might be accessing some of the opening buildings and et cetera, businesses should practice social distancing when leaving home and still limit out-of-home trips, following the guidance that's available on how to do these things safely. And everyone should be monitoring for illness. And we should have no more examples of people who attend any event who are ill. So there's no, well, it's just a cold. This is not our current era. So back to our timeline, I want to tell you there are also some good things happening. So for example, remdesivir has been found to reduce the morbidity of those who are requiring oxygen or ventilation. So that's really good, and that's been deployed throughout the state now. In balance, we finally have an answer around hydroxychloroquine, a highly politicized malaria drug that has shown again and again to not be effective in the way that we all hoped it would be. We moved into phase 1 in New Hampshire as described, and very recently we've heard that dexamethasone can also reduce mortality. So remdesivir reduces morbidity, how sick people get, but dexamethasone, a very inexpensive, widely available drug worldwide, does help people once they're in that stage 3 of illness where their immune system is overreacting. So stay at home ended, and now the program we're in New Hampshire is called Safer at Home, and I know that there will be lots of questions about that. I draw your attention to the fact that these are online, lots of, I think, helpful practical tips about how to attend dining out, weddings, day camps, overnight camps, and we'll even come to opening movie theaters, performing arts, and as much as I can't believe it, amusement parks. So with that, I've taken a lot of our time with an overview, and I hope that we'll have adequate time for your questions.
All right. Dr. Talbot, if you want to stop share for a moment, I'm going to read off a couple of questions that I've received. The first comes from Rick Jurgens, who asks, in 2014, you spent 3.5 weeks working with Ebola caregivers in Sierra Leone. Upon your return, you described that country's healthcare system as overwhelmed and warned that a 3-week quarantine of returned American caregivers could put an unnecessary burden on those who had already spent time training and doing relief work. If in 2020 you were a Sierra Leonean doctor returning to your country from a visit to COVID-stricken America, what would you report back to your countrymen about the US healthcare and public health systems and the efforts here to balance quarantine requirements against other economic, social, and personal concerns?
There's a few very relevant issues there. Just historically, I did 2 tours of 6 weeks each in West Africa and feel as though that's been hugely influential to me in how I think about, indeed, collapse of the health system and that terrible balance of controlling disease and also allowing people to find a livelihood. And one of the things that also emerged dramatically for me, if I were that doctor returning, is that we need novel ways to avoid battle fatigue here, right? So this is not a sprint, this is a marathon. And I think that the very slow emergence of strategies to maintain focus, to remain socially distancing, wearing our masks in public, all of that. I need creative people who can empower our population to continue that. We need a change in that culture also, to not tolerate and rather enable people to stay home when they're sick. So will we ever shake hands again? I don't know. But I think that one thing we should say collectively is that we won't show up in public when we have illnesses, because this is going to kill people. So probably lots to say on that topic. It is quite a heartbreak that this isn't theoretical, you know, that as said, this has moved into the global south. And if you look at pictures of Manhattan and Washington State and how disabling it's been and is becoming in Houston, for example, the countries that are global south generally have no such capacity. So we're you know, going to look at a very high morbidity and mortality, plus the derailing of normal health care, such as for tuberculosis, HIV, and malaria. So.
Okay. All right. We have another question from Margaret Green regarding the zoonotic aspect. You mentioned the importance of the wildlife trade. Why don't people highlight the importance of monoculture of animals in the context of industrial farming? Hasn't that been implicated as a source of zoonotic disease and other outbreaks in recent years?
Yeah, I like that. Finally, public health, animal health, and planet health have come together as one health. So this is the rubric that teaches us and supports the fact that we have to work together to maintain a healthy society. And yes, we do indeed pay attention to domestic animals as well. And they've been indeed an example of disease transmission to humans, especially with regards to the overuse of antibiotics for growth promotion in domestic animals. So I didn't know it, that using antibiotics in suckling pigs, for example, makes them grow up bigger and faster, and so they're commercially more viable. The inadvertent, the unintended consequence is that it's engendered a whole lot of drug resistance among humans for those antibiotics. So yeah, we're intertwined, we are connected, and we absolutely need to recognize that. The role of climate change is one that I watch very closely also as a disease investigator, that pathogens are greatly favored by a warmer, moister planet and the fact that we are encroaching on wildlife habitat. So that's One Health. And I do strongly endorse the continued momentum we have toward considering disease control within the One Health context.
Okay. From Kimberly Perez, sorry. PEPFAR has been working on these testing issues for years for both HIV viral load and for EID and HIV exposed infants. How is it that our federal government, the CDC, the White House Task Force, is failing to coordinate this for the COVID-19 response in this country when we've been coordinating it in countries overseas for the AIDS epidemic for over a decade?
Sure. Lots of political intersections with this disease that many of us could have seen coming, but probably didn't see coming in its fullness. So we will be learning about the failure of early testing for a long time to come. The first hot wash or initial analysis does suggest some really key missteps. One being the CDC is not a diagnostic manufacturer, and yet they were put in a position to create our PCR test in a facility that wasn't designed for mass production. So I think that that's a key feature. Second, we have an administration that has, you can see I'm going to weigh my words carefully here, that may not have a typical trust of the science and the motivation of those who are promoting some of the interventions, such as mass testing, business closures, et cetera, and therefore that's been influential and disabling to some of the response. So, Kim, your question is good. I have a feeling that you've thought deeply about this, and I think we will continue to grapple with it as a society for years to come, especially as this is not the last emerging infectious disease we're going to deal with as a species. So we do need to learn from these experiences.
I'm going to combine two practical questions from Jackie LeBlanc. I was told that antibodies post-infections are weakening even over a 3 to 4 months period. Is that correct? But I'm going to combine that with Chris Soit, who's asking, can you please explain again why culture testing is not being done? I'm very bad at two-part questions. Inevitably, I'll forget the second one, but I'm glad for the question on antibody decay, if you will. So for some infectious diseases, when you get infected and you live through it, that's great. You're never going to get that disease again. You know, there's plenty of examples of that. There's also diseases at the other spectrum where you can have the disease multiple times. For some reason, your body just doesn't mount appropriate antibody. Or even if it does mount appropriate antibody, it goes away. It decays over time. So we're looking very closely at where SARS-CoV-2 induces antibody. Some of it looks chaotic and not useful to prevent future infection, but some of the antibodies that most people produce are so-called neutralizing. That is, they don't seem to allow reinfection. The most recent data, as you've alluded, is that those antibodies decay, are no longer detectable within about 3 months for a significant portion of people. So I think that's really bad news on the front of, do you think we're going to just get infected and then never get infected again? So ultimately we'll accumulate herd immunity that prevents the R0 from propagating infection. We don't know. You know, even if our tests can't detect neutralizing antibody, doesn't mean it's not stored up in the memory of some of the cells that make antibody when it's needed. That is to say, even if my antibody test goes negative after testing, I still have lymphocytes that stand at the ready, that if they see the SARS-CoV-2 again, they'll make all the antibody I need. That's my hope, but we don't have that evidence right now. And let me think if I could remember that second one. Oh, why aren't we culturing? Hey, I remembered it. Because it's dangerous to the laboratorian, it's time-consuming, and it's expensive. So it's just not a practical method. Even the PCR, which takes only several hours to run, is not so convenient because it has to be transported to a central lab. That would be even more so for culturing. This is a highly specialized technique, so it's not going to serve us in the long run. And I'm going to paraphrase a series of questions regarding some practical items. Someone is asking about the importance of face coverings. Are they really effective? What about cleaning packaged groceries, protecting your clothing? And does washing surfaces actually do any good?
Yeah, so first, and very enthusiastically, absolutely face coverings will work. So you've heard this presented in lots of different ways, and I take it, my way is that certainly my mask protects you and your mask protects me, but if that's not good enough for you, you know, I think that in places where people cannot social distance, your mask also protects you. You know, if you're on a crowded subway and somebody sneezes at you, your mask has just caught that. So studies show, some of the larger studies now under closer scrutiny, but I would say with no hesitation, we have to embrace a culture of masks now. This is what's going to help drive this down, keep this down, protect you, protect others. So I don't think there's any doubt about it. No credible disease investigator, epidemiologist, clinician is saying otherwise. We are getting fatigued of it. You know, and that's my earlier comments, battle fatigue. How are we going to face that? We have to address it. The other efforts to clean food that comes or your surfaces at home, I have less enthusiasm for in preference for hand hygiene, right? So what are we talking about with fomites? That is, if somebody handled your grocery order who happened to have touched their face or nose while they had contagious virus and then touched your grocery, first of all, the virus is pretty fragile. It's going to fall apart. If it hits sunlight, it's going to fall apart in the wrong temperature or humidity. If it should happen to arrive intact to you, you can't touch it and inoculate yourself if you're cleaning your hands regularly. So I think you get a bigger bang for the buck, if you will, by also embracing the hand hygiene routine. So think now, where's your Purell? You know, everybody should have it in their pocket, in their bag, at their home, on their desk, at their front door, etc. So we also need to find the product that works for you, you know, like the small bottle, the big bottle, the place it everywhere, keep it in your car. And that's going to overcome the almost theoretical risk that fomites have an important role in this. Like, they just don't. We've studied that a lot. Public places, that's a different thing. In studies of airport personnel in Miami, 52% are PCR positive. So clearly disease is concentrating in some places, and that means that frequently touched surfaces, like the doorknobs, the handrails of the escalators there, the cart handles, they're probably a lot more contaminated than any grocery that comes to your home.
Okay. And I think I'm gonna, we're getting close to the end of the time. I'm gonna close out with a question from Jamie Horton. Do you, as an epidemiologist, envision a higher risk of health pandemics going forward? And if so, what lessons are gonna be critical in aiding our response?
Yeah, thank you for that question. I'd like to say that again, definitely. You know, the rate of acceleration of emerging infectious diseases, the majority of which are coming from wildlife and the way that we interact with wildlife in really new and sometimes perverse ways in terms of the pangolin being harvested in the thousands for aphrodisiac effect of their scales. I think this is going to render us vulnerable going forward. So SARS-CoV-2 now, what's next? We're watching Nipah virus, we're watching lots of emerging infectious diseases globally. Our attention is here on SARS-CoV-2, but thankfully there are others who are attending to what's coming next. So culturally, I'd like to say again that it may be that for a long time to come, we'll have to think about that hand shaking may not be the safest way for us to interact. In West Africa, we did Ebola, where you could touch elbows. That seems safer than the fact that as humans we touch our faces, our mucosal surfaces of our face often, and that's where viruses have evolved to hang out, waiting for that opportunity. I think that we, as a species, as a culture, need to, again, allow people who are not feeling well to not come into society, to be at home. But a lot of jobs don't allow that. And there's pressure, even for doctors, to come into work every day, no matter how you feel. Yeah, I think the One Health principle is also going to be something that if we continue to embrace it, understand it, and work together with all the right disciplines, we'll be better poised next time. These all-cause preparations are going to be important, such as having something driving diagnostic development, vaccine development, drug development that isn't only capitalism, which doesn't always address what we need when we need it, and looking to restructure both CDC and World Health Organization in ways to be appropriately responsive when the next comes. So thanks for that question.
So thank you, Dr. Talbot. And I'm going to turn over to Dr. Joan Sanders once again. Go ahead, John.
Dr. Talbot, thank you very much for a very, I would say, amazingly concise but thorough overview of a terribly complex problem. And the complexities, I follow the emerging literature as well as I can. And I'm just flabbergasted. You don't pass a day without some new and usually disturbing aspect of this particular disease coming to light. And for your ability to capsulize and present this in a fully understandable manner, thank you very, very much.
As said, it's been a pleasure. Thank you very much for having me, Dr. Sanders and all.
Thank you.